friends, next we are going to see one of the important videos, that is how to insert an intercostal drainage tube. This is a very important video. I have explained you how to put the tube here in this mannequin. Let me demonstrate. So you should know that triangle of safety. The triangle of safety, the lines you should not forget. So the one line running below is at the level of nipple. You have a line running here. This is at the level of fifth intercostal space. So at the level of fifth intercostal space, at the level of nipple, we have a line running here. This is the inferior boundary. And here at this point, we have the lateral border of pectoralis major. Okay, this is the lateral border of pectoralis major here. Another boundary. And here another boundary is latissimus dorsi muscle. So don't forget the three boundaries of safety triangle of intercostal tube insertion. So one boundary is at the level of nipple, fifth intercostal space. Another at the lateral border of pectoralis major muscle. Another at the level of latissimus dorsi. So this is a triangle of safety. So you can insert anywhere in this triangle of safety. Nothing will happen. No injury will happen to any of the important abdominal organs like liver and all. So you can insert between this triangle of safety. So now, what is the ideal place of insertion of this intercostal drainage tube? You can see this is an intercostal drainage tube. What is the ideal place to insert? If they ask you in single answer, the ideal place is fifth intercostal space at mid-axillary line. So at the mid-axillary line, in the fifth intercostal space is the ideal place to insert the intercostal drainage tube. So don't forget mid-axillary line in the fifth intercostal space level. So now the most important point before inserting this intercostal tube, let us assume this is the two ribs. If I am going to insert the intercostal tube, where will I insert? Will I insert it at the upper border of the rib or the lower border of the rib? So this is a very important question I have discussed in the theory. So please remember, we should insert the tube only at the upper border of the rib. Don't go at the lower border. If you go in the lower border, we can injure the neurovascular structures. So always you should insert at the level of upper border of the rib. Okay. So don't forget, we should insert at the upper border of the rib to avoid injury to the neurovascular structures. So now I am going to mark this mid-axillary line, give a local anesthesia, and with the help of 11 blade, I open the skin alone. Only the skin alone I will open with the 11 blade. Then I will use artery forceps to go into the muscles. So I will use artery forceps to play out the intercostal muscles, and I will push this tube. You can see this is an intercostal tube having markings. So this is a holes in the tube, multiple holes. So I have to pass this tube inside. So at the level of mid-axillary line, at the fifth intercostal space, I am passing this tube. So this tube should be pushed. All the holes should be inside the pleural cavity. So for a pneumothorax, I will push this tube towards the apex side. For a hemothorax or for the pleural effusion, I will push it towards the lower side. These are the two ways of putting the tube. So for a pneumothorax, it should point towards the apex. For a pleural effusion and other fluid collections, you should point downwards. So this is an intercostal tube. You should not forget the most important point. All the holes you are seeing here should be in the thoracic cavity. Not even one hole should be outside. If one hole is outside, intercostal tube will not function properly. So ensure all the holes are inside the thoracic cavity. So after you are putting the intercostal drainage tube inside, I have to connect this tube to a underwater drainage bag. So this picture should be, it's a very important tube you are seeing here. It is called as underwater drainage bag. See this bag first of all. Very important bag. It is not like a conventional drain bag. In this bag, if you see, the drain tube is going up to the end of the bag. Can you see? It is going up to the end of the bag. So not like other tubes where it will be only ending here. In this, the tube is going up to the end of the bag. So the purpose is, there is a mark here. If you closely watch, there is a mark here. I should fill with water up to this mark. This will be filled with the water up to this mark, and I will connect this tube with this. So this tube which is kept inside will be connected with this underwater bag, and it should be remaining at this level. So as you are putting this bag, please don't forget, we should fill the water up to this line so that the air from outside will not enter the tube. So very important point, don't forget, when I am putting a tube like this, air should not go from outside. That is prevented by this line. So we have to fill fluid up to this line. So if you miss to fill this line, the tube is without water, definitely air from outside will go via this hole. So through this hole, air will enter and patients will develop new complications. So don't forget this. So when you are going to put an intercostal drainage tube, the points you should not forget are, you should put the tube in the fifth intercostal space mid-axial line. Push the tube, all the holes should be inside. It should face towards the apex in case of pneumothorax. It should face to the base for a case of pleural effusion. And don't forget, this holes all should be inside the pleural cavity. Nothing should remain outside. So after the lung is fully expanded, after a few days or few weeks, we might be removing this tube. So most important point, when I'm going to remove that tube, I should ask the patient to be in full inspiration. They should not be in expiration. Ask the patient to take a deep inspiration and you remove the tube and immediately seal this hole. So immediately you should seal the hole here, otherwise air from outside will enter. So you should take out the tube and immediately seal the hole. So it's very important point. And one important question which is I have discussed in the theory part is, if I keep a tube like this and I am putting the tube like this, how to know whether the intercostal tube is functioning or not? I can say the tube is functioning or not by seeing the air-water column will be here. That will be moving up, moving down, moving up, moving down in the case of functioning intercostal drainage tube. So this is about the intercostal drainage tube. Please remember all the salient points of putting an intercostal drainage tube, which is a very important procedure for interns as well as for residents. So this is very important procedure either in an elective situation, also in emergency situation. So please don't forget about intercostal drainage tube.
Welcome friends, let me discuss the brief outline before going to the mannequin explanation. Let us start one by one. The first topic we are going to discuss, as an intern you should know everything about intercostal drainage tube. Some basic things as intern you should never forget, and one of the most important thing is putting an intercostal drainage tube. So one of the most important topics, please focus. This is a classical tube shown here, intercostal drainage tube. In this tube, if you see the tip is little blunt. So anatomy of the intercostal drainage tube you should understand. Please understand, this is a trachea, bronchus, and this is a lungs. So this is a lung. So where am I going to put the tube? First of all, you should know that. Where am I going to put the tube? This is a visceral pleura. Okay, don't forget, this is visceral pleura. And over that, there is a visceral pleura. Over that, there is a parietal pleura. This is pleural space. Usually, we'll have 20 ml or 30 ml of maximum space. 20 ml of fluid can be accepted. Even that is not seen usually. It is a mostly obliterated space called as pleural space. And this is the rib cage. This is a rib cage. So these are the ribs, 1, 2, 3 like that. There are many ribs. So please understand the intercostal drainage tube, where it is put. You are going to put the tube into this space only. Okay, you are going to put in this space, in the pleural space. You should not go and injure the lungs or the visceral pleura. You are not going to injure. Please don't forget, I am not going to put the tube into the visceral pleura. I am going to put it only in this space. This is the space where I am going to put this intercostal drainage tube. So when I am going to enter through the ribs, I should not go and forcefully puncture the lungs, which is already injured due to trauma or some other reason. Lung is injured already, that is leaking air in pneumothorax or leaking blood in a hemothorax. Something is already happening. We should not go and cause more damage. So please remember, we should put a tube in this space. And to put in this space, I should be very careful. I should not go and poke the lung. We have a blunt tip. Because we are going to go through the muscles. Going through the muscles after opening the skin incision is going to be a simple phenomenon. We have to go through the muscles with a blunt tip. That is a typical intercostal drainage tube. Nowadays, intercostal drainage tube is coming in this way. And this is a inner one which will be removed out once the tube is inside. So this is the inner one which is having a blunt tip to enter the thoracic cavity into the pleural space. Please don't forget this basic thing. So intercostal drainage tube, when you are going to insert, I am going to insert this tube in many places like pneumothorax, air in this space, pleural effusion, you can put this, pyothorax, pus in this place, you can put this, hemothorax, blood in this space, pneumothorax. So in most of the problems in the thoracic cavity, especially collection of blood in this space, we can put this intercostal drainage tube. Please understand the basics behind this tube. So to understand this tube, you should know this thoracic cavity is a thoracic cavity which is fully negative pressure. Okay, this is a pleural space. Please don't forget this is a pleural space and it's a negative space. It is having a negative pressure of minus 4 millimeters mercury. Therefore, if I put a tube like this in the thoracic cavity with all its holes inside the chest, what will happen? This is 4 millimeters mercury. Atmosphere is 8 millimeters mercury. The atmospheric air pressure, this area is 5 to 8 millimeters mercury. So what will happen? Naturally, thoracic cavity will suck the air from this way like this. So therefore, I should not leave this tube outside. I should keep this tube in a water. Inside the water, I should keep like this. Inside the water. If I keep this inside the water, the fluid from inside will come out, but will not go from outside to inside. So this is a concept. So in no other place we keep an underwater drainage tube. Only place we keep a drainage tube under the water is intercostal tube, because atmospheric pressure is positive, inside pressure is negative. Therefore, we should not keep it in a place where it is outside. So please remember, this is how you should keep the tube. You can see the pleural space, we have put a tube which is kept in the underwater drain, and whatever coming out, for example, air will go out like this, blood will go out like this, whatever coming out will be taken out via this way. So this is an underwater drainage tube. It is an underwater sealed tube, so that air from here will not go back, only it will go like this. So once you put a tube like this, I can see this air water column in the tube. Very important. Please understand, this is air water column. I will be asking a question on this later. Just remember, this is an air water level which is seen in the tube moving with the respiration. So ensure all the tubes are inside, all the holes in the tube. For example, these are the small holes in the tube. No, this is one hole. So all these holes should be inside the thoracic cavity. Don't forget this. So inside the thoracic cavity, it should be there. So this is an underwater drainage bag, which is actually, when it was manufactured, it was like this. We will fill with water up to this place here, and this will be empty. So whatever coming out, we will pour and remove it like this. But now it is not coming like this. Now we are having a simple bag like this. This cheaper one. You can see the tube is going up to this line. Up to this line, you have to, as an intern, your job is to fill the fluid. Don't forget, we should fill the fluid up to the mark level. If you don't fill it, naturally air will come from like this and go like this. So this is a new type of underwater drainage tube. Instead of making it fully compact plastic, small plastic bag like thing is also available now. These are underwater drain bags. Please don't forget, we have to connect to the intercostal drainage system. So now you are going to put the intercostal drainage tube. Where are you going to put? That is the most important thing for your exams. As an intern, you should know the triangle of safety. So this is the axilla. Okay, the apex is axilla. Axilla is the apex for putting the intercostal tube. Anteriorly, you have the lateral border of pectoralis major muscle. Okay, that is a pectoralis major muscle is found on the anterior border. Posterior border is latissimus dorsi. So very simple, anteriorly pectoralis major, posteriorly latissimus dorsi muscle. These are the two important boundaries. In between this, the inferior boundary is formed by a line drawn at the level of nipple. You can see it is at the level of nipple. So this is corresponding to fifth intercostal space. It corresponds to fifth intercostal space. We draw a line horizontally. So this triangle is called as triangle of safety. Because when you go below this line, there will be spleen might be coming. On the right side, liver might be coming. You may injure the spleen and liver. So at the level of this nipple level, we have to put a line, imaginary line, and you put the tube anywhere in this place. But ideal place is fifth intercostal space, mid-axillary line is the ideal space. If they ask you one point, you can write as in fifth intercostal space, mid-axillary line. Otherwise, nothing will happen. You can put anywhere along this triangle you can put, but we commonly put in the fifth intercostal space, mid-axillary line. I have to, first what I will do is, first take a local anesthesia, infiltrate in the place of you are going to do the thing. So under local anesthesia, infiltration of skin. So with the local anesthesia, infiltrate the skin, make an 1 centimeter incision. You make a 1 centimeter incision on the place you have infiltrated the local anesthesia. Now you have to palpate the ribs. There are 2 ribs, no? You should palpate at the upper border of the rib only, you should insert the tube, okay? You should not insert it on the lower border. You should insert at the level of upper border of rib. You should insert the tube at the level of upper border of rib. Don't put it in the lower border. Why? Why should I not put the tube in the lower border? That is very classically given by this anatomy. So if you see here, this is a way I am going to enter, no? So if I enter through the lower border, after penetrating the external and intercostal muscles, the intercostal muscles will be there. After entering the muscles, if I go in the lower border, that is containing neurovascular bundle, intercostal artery, intercostal vein, nerve. So if I go here, I may injure this artery, vein and nerve. Therefore, I should always go like this only. I should go in the upper border of the rib. Go along the upper border of the rib. Don't go along the lower border of the rib to avoid injury to the neurovascular structures. And as the tube is entering, you can see from this picture, in this picture you can see the tube is going upwards towards the apex. That is done for pneumothorax. In cases of pneumothorax, we have to put the tube towards the upwards. In a case of pleural effusion and other conditions, you can go towards the downwards. So point the tip towards apex in case of pneumothorax, point it towards the base in case of pleural effusion. So in hemothorax, if the patient is bedridden, we will pass it upwards. If the patient is mobile, we can pass it downwards. So hemothorax, you can decide according to the patient's condition. But in pneumothorax, always towards the apex. In a pleural effusion and other conditions, it should be pointing towards the down. Okay, don't forget these 2 points. So we do intercostal drainage tube after esophagectomy and all, we point it downwards only. So we point it downwards to remove any collection which is happening after esophagectomy. Okay, so this is very important concept. Don't forget about this in insertion of intercostal drainage tube. So you can see this is one of my trauma patient with the hemothorax. We have put a tube like this exactly on the 5th intercostal space in the mid-axillary line. You can see the tube is inserted and you can see blood is coming out. This is an intercostal tube insertion. You should ensure the hole is not outside. All the holes should be inside. It should be inside. So hemothorax is inserted into the lower border in this patient. I have now put in this case bedridden patient, I will be pointing towards upwards. Bedridden cases, it will be pointed towards upwards. In a normal patients, stable patients, we will point it downwards. But Bailey says in a hemothorax, it is pointed towards upwards because Bailey discusses on trauma patients. So we are going to put it upwards in hemothorax. So finally, pneumothorax, point the tip towards apex. Pleural effusion, point it towards down. Bailey says hemothorax also point it towards up because when the patient is lying down, it will get corrected here, so it will come out. But most of the time, as surgeons, we will put it downwards only, except pneumothorax. Okay. So these are the indications of thoracotomy. When will you do? You have put an intercostal tube, so much of blood is coming, you have to go for thoracotomy. If the blood coming is 1500 ml, as soon as I put a tube, 1500 ml blood has come in a blunt trauma of chest. More than 1000 ml is coming in a penetrating trauma of the chest. In a penetrating trauma, more than 1000 ml has come and more than 200 ml coming per hour for the past 4 hours. So past 3 to 4 hours, every hour I am getting 200 ml per hour. So more than 1500 ml in a blunt trauma, more than 1000 ml in a penetrating trauma and more than 200 ml coming per hour in any trauma. You should think of thoracotomy, immediately shift the patient to theatre and do a thoracotomy because in these cases, there is some major vessel which is bleeding like an aorta or a IVC or a bronchial artery or some major vessels in the thorax is bleeding. So most important questions expected in the internship is after putting the intercostal tube, the underwater bag should be below the level of chest. It should not be above the level of chest. You can see patient is lying like this means the tube bag should be below the level of chest as like this. And how to know this ICD tube is functioning or not? This is the question I told you before. We should be sure that the fluid is moving up and down. When you are putting the tube, we should ensure the fluid is moving up and down in this. As you take breathing in and out, there will be movement of this air-water column. Air-water column will be moving up and down. That is a very important point. So how to know ICD tube is functioning? If the air-water column is not moving up and down, you should ensure all the holes are inside. It is probably because 1 or 2 holes has come out of the thoracic cavity, so it is not functioning, number 1. So or there is a block in the tube by some hematoma. So if the tube air-water column is not moving up and down, either it is not in the correct position, it has come out, the hole has come out, or there is a clot which got obstructed in the tube. So these are the 2 common causes for air-water column not moving up and down with respiration. Another method of knowing the intercostal tube is perfectly in position is always we take an X-ray. You can see this X-ray. The X-ray shows the intercostal tube is pointing towards tip and all the holes are inside. So all the holes are inside the thoracic cavity. So this is how you confirm the intercostal tube is positioned or not. Okay.